And thank you, everybody, for sharing this time with us today. I deeply appreciate it. Working on policy at the state level is sometimes just so challenging. As a veteran of a state legislature, I understand that, I think, more than many. And I know we have many legislative veterans in the audience as well as advocates today. And what I'm hoping to convey over the course of the next few minutes and helping to set up the day is just how critically important the need is right now and what essential opportunities are in front of you to be able to make a difference in so many lives of people who are affected by mental health conditions. And I just want to say something in general about mental health conditions, and that is that for much of the past couple of decades or so, some people have tried to draw a distinction between so-called serious mental illnesses and other kinds of mental health conditions. But I want to tell you that I've always tried to treat all mental health conditions, all mental illnesses seriously, and not just assume because somebody is at the earliest stages of something like anxiety or depression or even psychosis, that it's not as serious a matter for us as when they are at the later stages of those kinds of conditions. And I think some of the information that I'm going to share here at the beginning may help to illuminate that. At Mental Health America, we have an online screening program that many of you know about. But anybody can come find us on the web and take a free, anonymous online mental health screen. And the screening tools that we use are the same screening tools that are used by most clinicians to help diagnose depression, anxiety, bipolar disorder, post-traumatic stress, eating disorders, psychosis, and several other mental health conditions. And in 2020, in the aftermath of the pandemic and during the pandemic, we have seen a dramatic increase in the number of people coming online to take a mental health screen. In the last year alone, more than 2.5 million people took a mental health screen just at Mental Health America's screening site. More than 800,000 of those people had moderate to severe depression. Another nearly 500,000 had anxiety, and really close to that number had psychosis or concerns about psychosis, many of whom were positive. Now, mental health conditions at their earliest stages are still serious mental health conditions. And I think anybody who has been experiencing anxiety or depression over the course of the past year in the aftermath of what we have all been going through understands just how serious these matters are. But just to emphasize, these impacts have been felt more deeply by children than they have by adults. And think about this. We've known half of mental illnesses emerge by the age of 14, making these diseases of childhood. But in the past year in particular, the ill effects of dealing with the pandemic have been concentrated on our young people, particularly the 11 to 17-year-old age group, 90% positive for conditions like depression. But don't let that stop you thinking about older groups if that's your area of interest, because more than 60% of people over the age of 65, my age group, have also been experiencing depression, who have used our online screening tools for depression over the course of the last year, many of them for the first time in their lives. So these are serious matters, and we have documented what an increase there has been in mental health conditions and mental health responses during the course of this past year. And as a result of that, we have led an advocacy movement along with a number of other advocacy organizations to try to get more resources for mental health. And we have been successful to date in getting about $4 billion added in COVID relief bills that have passed the Congress and been signed into law by the president already. And those $4 billion are far more than the federal government has put into behavioral health conditions at any time in the past, frankly, and honestly, a significant amount of money that can help offset a lot of the decreases that have been made to nonprofits or have had to be made to nonprofits by the states over the course of the past several years. Now, I was a state legislature back in the 1980s when we first got the mental health block grant, for example, and the funding at that time for the mental health block grant was actually higher in real dollars than it is today. But the additional dollars that have been put into that block grant give those of you who are working at the state level literally across the country more than $1 billion more, $1.5 billion more of dollars that will come into the states that can be used for a wide variety of initiatives, many of which will be talked about in the course of the day today. But it's so critically important, I think, that you understand at the state level the power you have to be able to spend these dollars creatively and innovatively. We didn't fully understand the opportunity that we had when it was handed to us back 40 years ago. But now I do understand that these dollars, largely unfettered and unencumbered, which have to be spent on behavioral health services, give you the opportunity to invest in children's mental health, if that's where your interests lie, to invest early in early identification, early intervention, when kids are still in schools, if that's where your interests lie, or to invest at the back end of services after crises have occurred, often long after the first symptoms have occurred, to try to do crisis interventions that will help people come out of the jails and prisons, that will help people come from homelessness into housing, that will help people get jobs and job opportunities, that will help people get educational opportunities, that will help people at any stage of the way along journeys related to serious mental health conditions that can often be extraordinarily long and stretch out over decades. Now, I can't underscore enough the opportunity that exists already and the prospective opportunity that may come later in the year, because there are competing bills in Congress right now that you've all been seeing, where the president would like to see another 1.9 trillion spent in relief, and the Republican counterproposal offered by Republican senators had about $600 billion in additional COVID relief. But I want you to know, in both of those initiatives, because of the strong bipartisan support for dealing with behavioral health conditions, there's an additional $4 billion put into the block grants primarily that would also be coming to the states. So not only can you use the money that have already come in, but you can anticipate that in the course of the next month or two, you may get yet another infusion of dollars to be spent only on behavioral health, giving you literally tens of millions of dollars, some of you hundreds of millions of dollars that you've never had in your states before, that will give you a chance to shore up the safety net system as it exists today, but also to build the foundation for a new behavioral health support and services system that could help so many people and will help so many people, that could change the trajectories of lives that have been characterized to date by suspensions and expulsions from schools when symptoms first emerge, from evictions from housing when acute symptoms flare up, from losses of jobs when people can't be supported adequately in the workplace, to a life within a revolving door of occasional hospitalization, frequent incarceration, and chronic homelessness that often befalls so many people before they ultimately lose their lives. Now, so many people in the course of the last year have told us, particularly young people, particularly people of color, particularly people in the LGBTQ community, that the suicidal ideation that they are feeling, frequent thoughts of suicide or self-harm, are overwhelming. And that literally hundreds of thousands of people have come to us looking for help with these thoughts of suicide or self-harm. And that's at just one end of the spectrum. So many other people are coming to us and coming to you, looking not only for services that will help abate their feelings of hopelessness, help abate the loneliness that they're feeling, help abate the financial difficulties and stresses that so many people are seeing, help abate the trauma that they're experiencing, help abate the grief that they're experiencing. But so many people are coming to us and coming to you looking for the opportunity to make things better for them across a wide population, not just a narrow population, that cuts across every age group, that cuts across every racial and ethnic group, that is concentrated among people who've historically had the greatest needs and have historically been left behind, but is being faced by everybody, whether they're urban, rural, white or black, brown or red or fit into any subpopulation group that you're seeing. Your whole obligation, your whole opportunity is to build access, because everybody right now is looking for support and everybody is looking for help. Now, I just want to wrap up by saying something that about me personally and why this is so important to me personally. As many people who know me know, my son Tim developed signs and symptoms of schizophrenia when he was 5 years old. I was in the state legislature at that time in Connecticut, just transitioning actually from the legislature to mayor of my hometown of Middletown, Connecticut. And I'd done a lot of work in behavioral health before this occurred. And I'm proud to say that some of the programs that I helped initiate actually helped serve my son, 10 years later, long after I was gone from the state legislature. So do this work and the legacy will persist. You may help others, but you may help yourself as well. But Tim, like a lot of kids Tim's age, really did end up being suspended from school frequently, really did end up being expelled from multiple schools in multiple states, really did end up in his adult life as being caught in that revolving door of hospitalization, homelessness, and incarceration. And as the pandemic hit last year, we no longer could get ourselves out to San Francisco to visit him. So we had to settle for an occasional phone call and an occasional virtual visit, which were each a joy to us, as we loved Tim deeply. But Tim, like a lot of people who get the life sentence of a serious mental illness, in his case, schizophrenia, Tim, like a lot of people, found that to be a death sentence. We got the word that Tim passed 3 weeks ago. And not only is that extraordinary news to get about your deeply loved 35-year-old son, but it just reminded me of how important every intervention has been for Tim, every positive intervention along every stage of his life's way. So when you go back to your states and try to figure out what to do, or when you listen even today to some of the opportunities that are going to be shared with you over the course of the next hour, think about Tim in this way. While many people wondered to me what they could have done near the end of his life to make things better for Tim, what I often told people was, it was what was done or wasn't done for him throughout his life that would have changed the trajectory of Tim's life and could have changed the trajectory of Tim's life. So whether or not your particular interest is criminal justice, whether it's social supports, whether it's parity, whether it's not working across state lines to make certain that people get services, whether it's around housing, whether it's around education, whether it's around deep end services, whether it's around early intervention, all of it matters. There is no bad answer. There is no wrong approach to take to support the people like Tim who are still with us. So I really want to encourage you to recognize that so many people are affected by mental health, that you have a unique and unprecedented opportunity as advocates and as policymakers to work together to make a difference at the state level. And finally, wherever you choose to devote your attention, you will make a difference. It will make a difference in the lives of people like Tim, and it will make a difference in the lives of people like me. So thank you for your interest in this area. Thank you for all the work that you've done to date. And thank you for your anticipated efforts this year in working forward to help so many people with such great needs.
Hello, everyone. It's great to be with you today. My name is Anna Bailey. I'm a senior policy analyst with the Center on Budget and Policy Priorities. And I'm going to talk with you today about the importance of investing in a robust mental health care system in order to promote an equitable recovery from the pandemic and the economic crisis. So I'm going to go ahead and share my screen and then turn off my camera so you can see my slides. So more specifically, I'm gonna start us off by talking about why a robust mental health care system is really essential to achieving a variety of state and local policy goals, the role that Medicaid funding has to play in mental health, and some of the stressors that the COVID pandemic and recession are putting on people, providers, and states, before ending with how state and federal policy can come together to move forward on that goal of strengthening a mental health care system. So mental care is about so much more than mental health. Often mental health care, we think about it as sort of this subset of healthcare off there to the side, when it's really foundational to many other health and social services and is key to the kinds of outcomes we want to see in our communities. So first, thinking about the healthcare sector, we know that co-occurring mental health, substance use disorder, and physical health conditions are really common. And we need a strong community-based mental health care system to make sure that people with chronic health conditions get the right care at the right time and to prevent unnecessary healthcare spending. You know, if someone with a serious mental illness also has diabetes or a heart disease, failing to address their mental health can really undercut their ability to manage their physical health. But it goes much further than that, well beyond healthcare. We also need to have a strong mental health system in order to provide education to all, to closing education gaps, to keeping families together and out of the child welfare system, to preventing people with mental illness from ending up in jails and prisons, and is also important for efforts to end homelessness. Now, the mental health system can't do all of that on its own. I'm not suggesting that, but it really is a necessary component to achieving those and other state and local policy goals. I know that Adam is going to talk some more later on today about the role of Medicaid and Medicaid expansion. So I'll just highlight a couple of things quickly about Medicaid's role in funding community-based mental health. It's really, in many ways, the backbone of our mental health care system for kids, for workers with low incomes, and for people with disabilities and chronic health needs. Covers a large portion of people with mental illness, and people who enroll in Medicaid really are more likely to access mental health care than folks who remain uninsured. And not surprisingly, for a lot of those reasons, Medicaid's a leading source of funding for behavioral health. So it covers a lot of the mental health costs in our communities. And this is really important because Medicaid is a reliable source of funding for providers. Makes it easier for them to plan and make investments in their staff and implement the best practices, going beyond a crisis management model. It's also really key when thinking about, as I was talking about earlier, managing the healthcare costs of people with complex needs. So we know from Medicaid spending data that people with behavioral health needs account for a really high portion, nearly half of Medicaid health expenditures. And this is speaking just about Medicaid, this chart is, but you see similar trends in private coverage and Medicare spending as well. So this underscores the importance of Medicaid in helping to integrate behavioral and physical health care, really being sort of a leading front in that effort. Turning to the crisis at hand, COVID and the related recession, we know is causing tremendous hardship, and that's definitely affecting people's mental well-being. With 1 in 3 adults struggling to pay for the most basic household expenses like rent and food, it's really not surprising that a lot of mental health providers are reporting increased demand for mental health services on top of the isolation that a lot of people are experiencing. And we also know the data is really clear that this is hitting low-income households and households of color particularly hard, which really threatens to worsen health and income disparities. And that is falling on our children too. More than 40% of kids are living in families that are struggling to keep up with rent or get enough food to eat. We expect that this is contributing to ACEs, or what are known as adverse childhood experiences, and traumatic experiences that can really contribute and lead to mental health challenges and substance use down the line as children get older. And this is on top of really alarming trends that we've seen in recent years around increases in teen and youth suicide rates. So in addition to meeting the urgent, immediate needs of families, early intervention mental health services will be really key to limit some of that long-term damage to children's mental health. So at the same time that the need for mental health services has been increasing, a trend that really could last well beyond the pandemic and recession, behavioral health providers are struggling to keep their doors open during this crisis. A lot of providers have seen big drops in their revenue on top of increases in costs as they've tried to collect PPE for their staff and their clients, and also ramp up telehealth and get really innovative about how they're delivering services during the crisis. So we've seen lots of providers reporting in surveys that they're having to cancel and reschedule clients and turn patients away, closing programs, furloughing and laying off staff. And on top of that, the providers are also now potentially facing Medicaid cuts and cuts to state grants that help them fill in their funding gaps. Those things are under threat that could lead to even more difficulty in meeting need in the coming months, but also in the long run. So I know this crowd knows this probably really well, but Medicaid, right, makes up a big chunk of state budgets. It's really only second to K-12 education funding. And states are seeing higher enrollment in Medicaid right now as lots of people have lost coverage and are finding coverage through Medicaid. And states are also using Medicaid, leveraging Medicaid to respond to the crisis. So I point this out mainly because I don't mean to minimize the challenges that states are facing right now, that these really tough out there. We know from past recessions, we've saw really significant Medicaid cuts and also saw really significant cuts to general revenue funded mental health and substance use programs as well. But cutting those funding sources will turn into even lower revenue for providers who, like we talked about, are already really struggling to meet that higher need and demand that we could see well into the future. And we saw over the summer, several states make some across the board provider rate cuts. Now, at the risk of stating the obvious, it's kind of a doozy of a year for state legislators. And at first glance, I think it can really look overwhelming and that states' hands are kind of tied. But we know that austerity and cuts are not inevitable. And we also know from decades of research that states don't cut their way to success. So I just want to take a second to highlight some principles around promoting an equitable recovery, including promoting an equitable recovery from the mental health perspective. And this includes focusing relief efforts on people who are facing some of the most urgent needs, including the providers who are serving low-income people who have lost work, communities of color that have experienced high rates of hospitalizations and deaths from, tragedies from the virus. This also includes protecting investments that are really key to both short but also long-term prosperity, thinking about those state-funded mental health grants and Medicaid funding as well. And a big piece of that, this third bullet, is around thinking about structural fixes rather than short-term solutions, like cuts that can prevention and early intervention in particular, which are really critical to those mid and long-term improvements in mental health that support all sorts of state goals like reducing child welfare involvement and improving education outcomes. But also cuts tend to hurt the same people that are already carrying the heaviest burden from the pandemic. So reducing services to people who are already struggling from lost jobs, and again, from communities that have been hit particularly hard by the virus. So that's a lot of sort of doom and gloom, but I want to share a little bit of good news. We've seen recent weeks several states that are proposing to make Medicaid funding increases during the state legislative sessions that have gotten underway this year. And some of those proposals have included increased provider rates that would help providers, mental health providers and other providers get on better financial footing during this crisis and respond to this growing demand for services that we expect to see for some time. So we hope to see more of that. And hopefully federal policy can play a role in making that possible. To date, thinking about that federal response, we've seen some federal policies enacted last year that were really helpful in stabilizing access to mental health care, helping to prevent some of that long-term damage to the mental health care system and access to care. This includes the increase in federal share of Medicaid funding that helps states to cover some of that increase in Medicaid enrollment, along with the spending that states are doing using Medicaid to respond to the pandemic. That provision also came along with some important coverage protections that help people, populations that often fall off of Medicaid or off of the Medicaid coverage, and then end up enrolling back on later on, but has helped people keep their coverage during the pandemic, especially really important for pregnant women and new parents. We also, of course, saw direct relief to providers, and in December, saw over $4 billion in behavioral health grants to states. These are really important short-term investments to help providers keep their doors open and keep access to care available during the crisis. But it's not enough to make up for potential state cuts and not enough to keep us on even footing in the long run. Looking forward to the rest of the year, there are likely three key opportunities for more federal support on behavioral health and crisis response. As you probably know, Congress is working right now on another relief package that would focus on addressing some of the most urgent needs. We're also expecting President Biden to announce a recovery package later on this year that would focus more on strengthening the economy and building up the infrastructure and systems that are needed for an equitable recovery down the line. And of course, there's the appropriations process. And I just want to touch base back on that rescue package, that relief package that lawmakers are working on right now. The president's proposal includes $350 billion in grants to states, localities, and U.S. territories to help deal with some of these budget shortfalls and help avoid cuts. along with another $170 billion for K-12 and higher education in particular. We'll probably hear some more details about what that package looks like by the time that you're watching this recording on the 12th. Continuing to think about the long game and that goal of building a strong, sustainable mental health system, fully leveraging federal funding for Medicaid is really key to that. And I know that Adam's going to talk a little bit more about this. So I won't spend too much time on this other than to point out that in addition to expansion, a key piece of this is using Medicaid's flexibility to cover a wide range of services and then wrapping grants around those services to fill in funding gaps for uninsured folks, for underinsured folks, to test new approaches, and also to really leverage Medicaid to build those cross-system partnerships that are so key for driving a variety of outcomes. With that in mind, I want to end where we started, about how mental health care is foundational for so many different state goals. As you all know from talking to people in your communities and conversations in other sessions today, there's tremendous and exciting opportunities to build relationships between mental health care and schools, to build relationships between mental health care and correctional facilities, to build relationships from mental health care to the child welfare system, as well as to the homelessness system as well. And I think what's really notable about that is mental health really is often at the center of those relationships and holds a lot of responsibility to making sure that they're effective. And I think, you know, using flexible grant dollars is a really smart way to jumpstart those kinds of innovation and build the capacity that's needed to have strong cross-system relationships. But in addition to that, mental health providers need a sustainable, reliable funding source to scale up the models that we know work and to make the most of partnerships and available funding. And that scale, reaching scale, is also essential, is really necessary to shifting the mental health system from having to spend so much of its time and resources on crisis management towards a model of prevention and early intervention that helps prevent some of those worst case scenarios to begin with. So I want to, with that, thank you all so much for your time, and I am really looking forward to hearing about your questions, insights during our discussions later today.
Hi, I'm Adam Searing. I'm with the Georgetown University Center for Children and Families here in Washington, D.C. I focus on Medicaid and CHIP, healthcare programs. Specifically, I work on Medicaid expansion a lot around the country, and I'm really happy to be here today and talk to you about the state of play of Medicaid expansion and what we're seeing now and what we might see in the future. So we'll talk about that. We'll talk about some of the research that's behind expansion and what changes we might see in the next few months or the year. So first of all, where are we with expansion? Well, I'd like to throw up this chart on the screen real quick. And this just gives you an idea of where we are right now. There are 12 states left. The 39 states in DC have already expanded Medicaid. There are 12 states left that are still refusing the funding for Medicaid expansion. And these states have been refusing for now 7 years. They are almost all in the South now. Just this past year, Missouri and Oklahoma, voters there voted to have their states expand Medicaid. So this is really becoming a problem of the South, unfortunately. And there are 4 states where 3/4 of the people who would gain coverage from Medicaid expansion live. And those states are Texas, Florida, Georgia, and North Carolina. Why are these states still holding out for Medicaid expansion? I think there's 2 main reasons. There's the ideological opposition to government program like Medicaid, and frankly, there's racial animosity. And I think we're really seeing that clearly now as almost all the rest of the nation has expanded, and it's just these states in the South. So that's where we are. Where are we going? Where are we going? That's the second thing. Well, look, we have got tons of research now after 7 years on what the effect of Medicaid expansion is. There's over 400 studies now that document the benefits when states expand Medicaid. I really think there's not been a more studied topic in healthcare policy in over a century. And what do these studies show? They show overwhelmingly positive benefits when a state expands Medicaid. Positive benefits for people's health, positive benefits for their finances, positive benefits for jobs and state economies. You don't have to be a partisan to look at the data and realize this. I'm going to show you another quick chart here. And this is just a summary of some of the studies around Medicaid expansion. And you can see there's just a wide range of studies from access and utilization of care to positive health outcomes. And the green is where those states are showing positive outcomes. So it just is, there's really no policy reason not to expand Medicaid. Examples that we show, we have multiple reports that we've put together just in the last year, and you can take a look at those if you're interested. For example, we took a look at how in this example, how Medicaid expansion affects the maternal health. So we know that expansion states, we've got healthier moms, lower maternal mortality, and healthier babies. I mean, this is just one example where we're doing this, but we've covered these reports like this in HIV, ending the HIV epidemic. Medicaid expansion states are having better success doing that. And most recently, Medicaid expansion states are having better experience in reducing the numbers of uninsured kids. So it really is a lot of research across the board. And I think if you talk to any researcher, they'll tell you it's a positive thing. So where are we going? Where are we going with Medicaid expansion? We've got these final 12 holdout states. There's a lot of interest in the new administration in Washington into making it easier for states to expand. They're talking about a number of different things, including some way for people who who are in these non-expansion states to sign up for, say, public option or the existing healthcare marketplaces. That's a tough option or a tough thing to get done, but I think it will get a lot of discussions here. There's also a discussion about incentives. A bill was introduced in the Senate yesterday to increase the federal funding for expansion. The federal government already pays 90% for expansion for states. They're talking about upping that to 100%. So it'd be zero cost for states to expand for the next 3 years. So that's a huge thing that we're seeing right now. Not every one of these things is going to pass. There's going to be a lot of discussion about that. It may be much easier for states to expand, and I think we're going to see that effect here this year. So what's ahead this year? Well, we've got 2 states, Mississippi and South Dakota, who are actively thinking about doing these Medicaid expansion ballot initiatives, putting the question directly to voters. And the 5 very conservative states that have considered these ballot initiatives, the Medicaid expansion has passed again and again. Idaho, Missouri, Oklahoma. It's just been pretty consistent. Utah, Nebraska. Otherwise, we've got several states that are actively talking about expansion. Kansas, North Carolina, They have governors who are very committed to expansion and also very much working with these are both Democrats in Kansas and North Carolina who are governors. They're willing to work in a bipartisan way with their legislatures in order to try and craft something that is acceptable to everyone in those states. Georgia is another state, a lot of discussion about expansion, election coming up for the governor next year. The Medicaid question was a huge issue in the gubernatorial election, in the elections in Georgia last year. I don't think anyone in Georgia who is currently in office wants to run on not expanding Medicaid. So a lot of interest in that. Same goes for Texas too. In some, I think we've got these holdout states in the South. There's a lot of interest in the federal government making it easier for states to expand, and a lot of political push, whether it's on ballot initiatives or just through legislatures and from governors in order to expand. So look for some action this year. Thanks a lot and appreciate the time today.
Good afternoon. My name is Dr. Kanika Harris. I am the Director of Maternal Health for the Black Women's Health Imperative, the only national organization that focuses on the mental, financial, physical, emotional well-being of Black women in the United States. Happy to be invited and to talk about the needs of Black women as it involves maternal and postpartum care. The Society of Maternal Fetal Medicine reported that if giving birth for a Black woman were an occupation, it will be the 5th deadliest job, more deadlier than a steel worker. I want us to let that really sink in. If we are neglecting and ignoring Black and brown moms during pregnancy and delivery, our postpartum needs are simply an afterthought. For Black and brown mothers that do survive pregnancy and delivery, they experience higher rates of trauma, putting them at risk for postpartum complications and postpartum depression and psychosis. Not surprising, women of color are at a higher risk of experiencing postpartum depression and less likely to receive help. They are also more likely to be undiagnosed and not heard from their providers. Excuse me. The consequences of undiagnosed and untreated depression can lead to substance abuse, trauma, pregnancy-related deaths, and in some cases, suicide. For some mothers of color, with the addition of competing issues and stressors, such as financial stressors, lack of support, transportation issues from appointments, unstable housing, they are more likely to experience postpartum depression, and this postpartum depression can also be exacerbated. Even after controlling for socioeconomic status and education, we are finding that Black and brown mothers are more likely to be deemed as unfit parents than white mothers. So this means if they have an issue with postpartum depression, they may not report their symptoms in the fear that someone from Child Protective Services may deem them unfit to take care of their children. And that's an important context to remember within all of this. COVID has only exacerbated these issues because women of color already experience bias in the healthcare system. Some of these issues are also missed with the telehealth options. Women are dying. Prenatal care is not as comprehensive as it needs to be with telehealth, and it can lead to pregnancy and delivery complications. We also are experiencing limited support from moms during COVID. And we know that Black moms are already at risk to experience more traumatic births. So this means that this can lead to issues of social isolation and can increase postpartum depression, especially if they are having financial issues or being alone with babies for long period of times with no break and not really getting the help that they need right now. Overall, we know that COVID has unveiled what communities of color have experienced and lived with for generations. And now we are disproportionately impacted and dying at higher rates from COVID. We know for expectant moms that they have a 50% higher chance of being admitted and a 70% higher chance of being intubated with COVID, and Black and Latino moms are having significantly higher rates and more susceptible to COVID and more susceptible to complications from COVID that will affect them also postpartum. The Omnibus Act, led by Congresswoman Underwood, is a comprehensive piece of legislation that now includes 12 bills to address the gaps in coverage in terms of health services and healthcare. It addresses issues stemming from social determinants of health when we're looking at housing, childcare, transportation, and addressing needs for mothers of color. Expanding postpartum coverage and Medicaid for 1 year is the Black Women's Health Imperative's #1 priority in terms of supporting the Omnibus Act, the Omnibus Act, excuse me. We really need postpartum coverage. We need comprehensive care. We need inclusive cultural care, especially for moms of color, that identifies their needs, that gives them a chance of having a really healthy and thriving first year as mothers, and also for their babies. Thank you so much for your time. Thank you so much for listening. And I look forward to this wonderful opportunity in this conference.
Mental health advocates believe that there are too many people with mental health conditions in the criminal justice system, and that people with mental health conditions are often mistreated in the criminal justice system. Of course, in the past year, there has been heightened scrutiny of police interactions with persons of color. This scrutiny has focused on the disproportionate number of people of color who are in the criminal justice system and how they are treated as well. Of course, one of the reasons that there are so many people with mental health conditions in the criminal justice system, and there are so many people of color in the criminal justice system, is that there are so many people in the criminal justice system. The United States locks up in its prisons on a per capita basis more people than any other country in the world. We're #1 in terms of locking up millions of people in our criminal justice system, in our prisons and jails. And we've been #1 for a number of years. I should say that that may be #1 with an asterisk. That is, it's possible that the government of North Korea locks up more people, or a higher percentage of its population in its prisons than we do. But they don't share with the rest of the world good data. And I should just say, I refuse to go to North Korea to collect that data. It just doesn't seem safe to me. Now, because of all the attention generated by the death of George Floyd, and unfortunately other people as well, many states are now focused on reforming their police practices and reforming their criminal justice system generally. Illinois is doing so. Our legislature just enacted a 764-page bill that just passed both houses of our state legislature on January 13th. This bill is called the Statewide Use of Force Standardization Act, but it covers more than just use of force. The bill is awaiting the governor's signature. It is expected that he will sign this bill. Much of this bill is not at all focused on the people with mental health conditions. Indeed, the #1 provision in terms of controversy and publicity, both in Illinois and indeed in other states as well, is the fact that Illinois became the first state to abolish cash bail across the whole state. Other places have done this in localities, but Illinois is the first state to do this on a statewide basis. I will now talk about the provisions that are specifically focused on people with mental health conditions, since I think that's more germane to our conversation today. And it may very well be that those provisions may be useful to other states and advocates and legislatures and governors in other states. So one of them, to start right in, is called training related to stigma, so that it requires that the police be trained about the stigma related to mental health and substance abuse conditions. Again, not a large provision, but it is part of an effort to make sure that the police understand the nature of mental health conditions and our attitudes toward them. A second important provision is that a key criminal justice agency in our state has now been directed to divert some of its funds to deflection programs. That is, programs that are designed to keep people out of the criminal justice system, that is people with mental health conditions, or to divert them before they get in the criminal justice system. So we will now have some funding from this agency devoted to reducing the number of people with mental health conditions in the criminal justice system. And prioritized for the use of this funds are communities that have been underfunded for mental health funding and underfunded generally, and communities of color and communities that have been disproportionately affected by the war on drugs. So we think that that provision may help us keep people of color and people with mental health conditions from ever even getting into the criminal justice system, or if they get into it, from ending up in prisons and jails. A third provision is a detailed provision relating to enhancing the training of police officers generally. And it requires that the police be trained about CIT, that is crisis intervention training, that they be trained about diversion programs that we already have in our state. Many states have so-called CIT training or crisis intervention training. It requires a minimum number of hours, which has been enhanced by this bill, and also adds to the things that are required for this training. We think, again, part of the answer to improving police conduct is if police know more about the nature of mental health symptoms, what treatment resources are available, so that people can be deflected out of the criminal justice system. Another important provision in this bill has to do with screening police officers for their own mental health conditions. It is unfortunately the case that police officers have a disproportionate amount of mental health conditions themselves. Being a police officer is a stressful job, so it's not unusual, particularly in large cities, but anywhere in the country, for police officers to have experienced traumatic conditions, and that trauma has either caused or enhanced various mental health conditions. So that police officers in Illinois now will be screened for mental health conditions. Unfortunately, too many police officers are committing suicide. Again, the suicide rate among law enforcement is substantially higher than the general population. Not a good thing. We need to take care of our police officers if we expect them to take care of us. We need to care about how police officers, about their mental health conditions, and make sure they're as well as they can be. Yet another important provision is that now police departments will be required to report on a periodic basis their number of police officer encounters with persons with mental health conditions. It is unfortunately the case across the country that police are the first responders to many mental health emergencies, often that don't involve criminal behavior, but the police are simply called to deal with a mental health emergency. That's something we need to work on fixing. But since it's true, we need to make sure that those encounters go well and that they get reported, and then we can begin to examine the extent to which there are bad outcomes and whether those bad outcomes could be prevented. Finally, we have created a provision that encourages all police departments across the state, when they are devising their use of force policies, to create specific use of force policies for people with mental health conditions. People with mental health conditions, sometimes when their condition is not being well treated, may behave somewhat differently than other folks, or may respond to the police in ways that the police don't expect. And police officers need to take that into account. All of the provisions that I've discussed and the exact language in these provisions will be in a document provided to you. I would also say that one of the things that we are heartened about at Mental Health America is that many of these provisions are provisions that we have been working on and are reflected in an important statement that Mental Health America created just this past year, titled Mental Health Recommendations on Improving Interactions Between the Police and People with Mental Health Conditions. That statement will also be provided to you and has, in addition to some of the things that Illinois has started to do, a number of other important recommendations about how to improve interactions between the police and persons with mental health conditions. I think there's so much more work we need to do on this. The good news is that across the country, cities, counties, and states are experimenting with new ways of dealing with people with mental health conditions who come into contact with the police. And we have lots of opportunity for improvement. That's my optimistic way about saying that things are not great, but they may be getting better. And now is the time to help them do that. Thank you very much.
Well, thank you for having me here today. We at Alkermes are honored to continue our valued partnership with Mental Health America. My name is Frederick Ryan. I work in our Community Relations Division at Alkermes, and I'm here to discuss an exciting policy development in Massachusetts. Like many states, as a result of the Medicaid inmate exclusion, Massachusetts is a Medicaid suspension state that had historically suspended Medicaid benefits for all persons committed to our jails or prisons, whether convicted of a crime or simply held on a pretrial status. In fact, among the very first actions taken following the booking of a detainee in Massachusetts was to cause Medicaid benefits to be promptly suspended. Under the leadership of our governor, Governor Charlie Baker, who was honored earlier here today, and his health secretary, Mary Lou Sutters, it was recognized that for this transient population of pretrial detainees, many of whom are suffering with serious mental illness and substance use disorders, this policy was flawed. Prior to the COVID pandemic, the average length of stay in our jails was 28 days or less. And now, as a result of the extraordinary decarceration efforts due to COVID, that average has decreased significantly. The consequence of these efforts has resulted in the pretrial population falling through the cracks during these rapid incarceration and decarceration episodes and re-entering our communities in a suspended Medicaid status. Grassroots advocacy organizations and recovery coach navigators convened, aligned, and mobilized around this challenge and worked with the Baker administration and his health authorities to engage in some creative problem solving. This resulted in mass health authorities exercising their discretion to implement policy to maintain Medicaid benefits for all pretrial detainees in Massachusetts. Although the implementation of such a policy is complex in terms of records management software systems and ensuring the discontinuation of managed care and capitation payments, the policy decision itself was rather simple, straightforward, and did not require CMS waivers or other authorizations, so long as no federal match was sought during these periods of detention. There's no doubt that the continuation of healthcare coverage for pretrial detainees during detention and incarceration will facilitate treatment, continuity, and retention and care for this vulnerable and transient population. And I hope that other states will explore similar policy opportunities. Thank you again for having me today. And on behalf of the entire team at Alkermes, thank you for the incredibly important work that Mental Health America does every day.
Due to the coronavirus pandemic, the federal government issued temporary guidelines for the use of telemedicine in order to reach individuals in need of healthcare during the national lockdown. These guidelines not only proved successful in reaching individuals who were seeking care, including mental health counseling, but also proved successful in increasing access to care due to the relative ease of access that telehealth provides. Telehealth can be a big benefit for those who cannot leave home, have no provider in the immediate area, or who might be concerned about neighbors and friends finding out that they are receiving mental health services. The state of Colorado decided to craft legislation making the use of telehealth in our state a permanent option, using the federal rules as our guide. We believe that telehealth is vital to ensuring the continuity of physical, mental, and behavioral health care for Coloradans during the COVID-19 pandemic and responding to any future outbreaks of the virus. So the Colorado bill, Senate Bill 20-212, had bipartisan sponsorship and bipartisan support. It applies to both Medicaid and the private insurance carriers and became effective on July 1st of 2020. For the first year on implementation, Colorado was able to use CARES Act funding due to the spike in mental health, anxiety, and depression conditions we were seeing due to the coronavirus. Moving forward, telehealth services will be paid for with Medicaid General Fund and the federal Medicaid match. So the main provisions of the bill in terms of covered services, it includes assessment, diagnosis, consult, treatment, and education. They can provide care management, suggestions for self-management, and make recommendations regarding the person's health care. Any healthcare or mental health care service via telehealth must meet the same standard of care as an in-person visit. It includes interactive audio, interactive video, or interactive data communications, which generally is chat. Technologies must be HIPAA compliant. Billing and payment for telehealth services must be equal to in-person visits. Private carriers in Colorado shall not impose specific requirements or limitations on the HIPAA-compliant technologies that a provider uses to deliver telehealth, including limitations on audio or live video technologies. And private carriers cannot impose different annual dollar maximums that are different than in-person care. They must require a covered person to have they shall not require a covered person to have a previously established patient relationship with a specific provider in order to receive medically necessary telehealth services. And they shall not impose additional certification, location, or training requirements on a provider as a condition of reimbursing that provider for telehealth services. Finally, our telehealth bill requires data collection and an annual report to the state legislature. So we will be able to see how effective and/or widespread the use of telehealth is in meeting the need of delivery of services. Since this legislation is so new, we do not yet have any data that can inform us of potential problems or pitfalls, challenges with private carriers, or the willingness of users to engage in this technology. In-person visits still must play a role for many individuals, and we do know that. But we do believe that telehealth is here to stay as a new mode of providing mental health services. And while it is not a perfect solution to reaching more in need, nor the only way to reach more of those in need, but telehealth does show great promise for providing services in rural and other underserved areas of our state.
Hi, my name is David Lloyd. I'm a senior policy advisor at the Kennedy Forum, which is an organization founded by former Congressman Patrick Kennedy to advance mental health and addiction equity across the nation. So I work on mental health parity and specifically enforcement of the Mental Health Parity and Addiction Equity Act, which, as many of you know, is the landmark legislation that was enacted in 2008. Which prohibits discrimination in the coverage for mental health and substance use disorders. And this has been a critical piece of legislation. I think, as many of you likely know, prior to the Parity Act and also the ACA, the Affordable Care Act, there was rampant discrimination in health plans against mental health and addiction care. So when people would seek services, those services would often be severely limited or denied in a way that simply didn't happen on the physical health side. So the Federal Parity Act of 2008 really helped change that and outlaws discrimination in mental health coverage. So we have been working with our partners to really enforce the Federal Parity Act by really making health plans demonstrate their compliance with the Federal Parity Act, rather than putting the burden on patients and their families. So one of the ways we do that is by having reporting requirements that health plans need to report to both state and federal regulators. There's been a lot of progress in the last couple of years of making sure that plans are demonstrating their compliance, but we do still have a long ways to go, and it really is incumbent upon regulators, both at the state and federal level, to be doing the analysis and doing the deep dives on what health plans are doing, to make sure that they're not discriminating against people with mental health and substance use disorders. And so another way that we are also advancing mental health parity is by looking at the lessons from a landmark federal court case that's a nationwide class action called Witt versus United Behavioral Health. And the Witt case has played out over the last few years, and there have been several important rulings both in 2019 and last November, where the court found that United Behavioral Health, which is the nation's largest managed behavioral health company, had wrongly denied coverage for 50,000 Americans across the country, half of whom were children and adolescents. And the court found in that case that United had used flawed medical necessity criteria and used those flawed medical necessity criteria that were not consistent with generally accepted standards of care to deny these services. So recently, the court has issued a 10-year injunction against United Behavioral Health to use what are nonprofit clinical criteria from organizations like the American Society of Addiction Medicine to make medical necessity determinations. And so the Kennedy Forum has taken this important ruling, and with our partner, the Steinberg Institute in California, enacted really groundbreaking legislation last year that took effect in January that requires all health plans in California to follow generally accepted standards of care and to make medical necessity determinations in a manner that they would make medical necessity determinations on the medical surgical side. So essentially advancing the parity requirements in an important way. And so the Kennedy Forum, after enactment of this bill, turned this bill into model state legislation named after former Congressman Jim Ramstad, who was with former Congressman Kennedy, the co-author of the Federal Parity Act. And so we are now pushing this legislation across the country, and are working with states to introduce this legislation. We're also very interested in making sure that the federal government puts standards in place, really forcing plans to follow generally accepted standards of care. And these are very kind of common sense standards, standards that, for example, say that you need to take into account the unique needs of children and adolescents. Another standard is that you need to treat the underlying condition and not just current symptoms. And yet another standard is simply that you need to make a multidimensional assessment on the patient's needs and not just look at one aspect of their illness. So we think that this is really important and will help advance the goals of parity and ultimately make sure that mental health and addiction treatment is equitably paid for, because without payment parity, we will not see that that people are able to get the access to the care that they need. So thank you for having me here today, and thank you for your advocacy on mental health. It couldn't be more important, particularly right now. So thank you so much.
Hi, my name is Charlie Husser, and I work in state and federal policy for the Alliance for Patient Access. Today, I'm going to be taking a few moments to speak briefly to you about step therapy legislation in the states as a whole, and then briefly about grassroots advocacy and how we're working in order to further the step therapy legislation movement in the states. And so I have a quick presentation that I'd like to share. So let me pull those up real quick. So to start off, what is step therapy? So step therapy is a utilization management tool, which is essentially a tool that is used by insurance companies to keep or hinder access to medications at the patient level. And so step therapy itself is a tool used where one insurance company will take the medication that is prescribed by a provider for a patient and say that in order to reach that medication, they must first try a number of medications, could be one, could be upwards of unlimited amounts of medications that the patients must first try before they're allowed to try the provider prescribed medication that they got from their visit. And so the core belief of step therapy is not getting rid of the practice, because at a medical level, when used by a provider, step therapy can be a great tool in the toolbox for providers. However, when it's utilized by an insurance company for mainly profit reasons, trying to get a patient to try other medications that are less expensive before moving on to the medication that was actually prescribed by the provider, that's the type of step therapy that the legislation that's run in the states tries to reform. And so no bill or legislation in the states would be complete without grassroots advocacy. Grassroots advocacy comes from the local patients, constituents, providers, the people at the local level near the state house or in the state. And so the local coalition will be usually the first step. A coalition will form, usually run or led by a group or a person on the ground. And then the local coalition will then branch out. A lot of times the advocacy tools that are used at the grassroots level, patient and provider stories, in person or virtual in the time of COVID, testimony. Written testimony is also very well received, as well as sign-on letters. Sign-on letters are different than in-person testimony or even written testimony because of the fact that it's usually led by either the local coalition or another group. And the point of it is to get the message to the either legislator or the regulatory agency, whoever it may be going to, and show the true support that is behind this kind of legislation. And so with sign-on letters, when you get upwards of 10, 20, hundreds of entities that sign on, this is when you're going to see a lot more support come from the bill. And social media support and outreach is another great grassroots advocacy tool. The social media support is really just a quick and easy way to show lawmakers that there is support behind this bill and that they want it to pass. And so when all of these are brought together and really done at the local level, that's when we see a lot of success at the state level. And so what does step therapy model legislation look like? And like I said earlier, we are not, we at the local level, at the coalitions, all of these legislations that are being run by many groups at the state level are not trying to ban step therapy. However, they're trying to reform it so that it's transparent, clear, and easy for patients to access the medication when they truly need it. And so the model legislation, clinical review criteria, clarification on what treatments have step therapy protocols before even submitting the prescription, transparent decision-making timelines and clear appeals process so that if step therapy is implemented by an insurance company, then there is a quick and easy process that allows them to access that medication. And usually the timelines that we see are between 24 hours for emergency cases and 72 hours for non-emergency cases. And then there's also the reporting requirement aspect of it, because without reporting requirements, if this were to pass, then there's no way of having that data and that numbers to show that step therapy requirements are actually going down. So successes in target states. I want to speak a minute about the legislative landscape in 2020 and 2021. So in 2020, there were 3 successes at the state level with step therapy bills in Louisiana, North Carolina, and South Dakota. And as of now, over 50% of states have passed step therapy legislation. And this is just a quick look at, as of right now, some of the target states and introduced states for step therapy legislation. The red are states that have had step therapy legislation introduced already, and the blue are states that are awaiting introduction or are target states at this moment. And just because your state might not be listed as either a state with bills introduced or awaiting introduction, that doesn't mean that there's either not a coalition that would like to introduce a bill or not possible to introduce a bill. So I just want to speak for a moment about federal step therapy efforts because of the fact that just because a bill is introduced and passed at the state level, it doesn't cover all insurance plans on the market. And so because of that, there's a federal step therapy effort. The Safe Step Act, HR 2279 and S 2546 were both introduced last Congress and are expected to be introduced in the 117th Congress as well. The federal step therapy legislation is a close mirror to the model legislation. And so because of that, it follows a lot of the step therapy requirements that coalitions and model legislation follows. And as I mentioned earlier, I'm Charlie Husser. If there are any questions about step therapy or utilization management tools as a whole, either in the state or federal level, please feel free to contact me at the email address on your screen. Thank you.
Hi, I'm Laura Evans, Program Manager for National and State Policy with Vibrant Emotional Health. Vibrant Emotional Health is the administrator of the National Suicide Prevention Lifeline, and this is the 411 on 988. We'll start with a disclaimer that the views, opinions, and content expressed today are not necessarily those of the U.S. federal government, including the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. So 988 has been designated by Congress and the Federal Communications Commission, or the FCC, as the universal telephone number to reach the Lifeline, which will serve as the National Mental Health Crisis and Suicide Prevention Line. So by July 16, 2022, the FCC has required all telecom providers to route 988 to the Lifeline, so that no matter if you're using a cell phone or landline or IP services, when you dial 988, you can reach someone for assistance. 988 also represents an opportunity to have a more connected crisis continuum. As identified by SAMHSA, there are 3 core elements for a connected crisis continuum, and they include having someone to talk to, so the crisis center through the Lifeline, having someone to respond, utilizing crisis mobile response teams or other deployment services, having somewhere to go that isn't jail or the inappropriate use of a hospital emergency department, through crisis receiving and crisis stabilization services. So those are the 3 core elements identified by SAMHSA, but you'll notice there are 4 puzzle pieces. And that's because I believe that there is an opportunity to include 911 and other physical health services, as well as utilizing the lived experience community in all components of the crisis continuum. So how do we prepare for 988? Well, preparation is already underway, and that includes model legislation from the National Association of State Mental Health Program Directors, or NASHPD. Their model legislation, with feedback from Mental Health America and Vibrant and others, includes connection to those crisis continuum. So ensuring that the crisis centers are connected with the crisis mobile response teams, crisis stabilization units, and includes a mechanism for states to generate revenue through a 988 universal surcharge. This is very similar to how 911 is funded through a 911 fee on telephone bills. And there's an opportunity for states, if they choose, to enact a similar fee to help pay for this crisis continuum. There are planning grants that have been issued by Vibrant to 50 states and territories so that they can convene all necessary stakeholders, including individuals with lived experience, the mental health community, and other policymakers to decide how 988 would look in their state. We anticipate additional rulemaking from regulatory agencies such as FCC on texting to 988, as well as geolocation. And I think most importantly, 988 is an opportunity to have a mental health response to mental health crises. All too often we hear the negative outcomes that can happen when there is a law enforcement response to an individual in crisis. And 988 really represents an opportunity to ensure that we are leading with a mental health response. So that's the 411 on 988. Here's my contact information if you have any questions, and thank you for having me.
Hi, thank you for joining me for Mental Health Education in Schools from Policy to Practice. My name is Amy Molloy. I'm the project director at the Mental Health Association in New York State. A special thank you to all the MHA staff for their efforts in organizing this town hall, and for our colleagues across the country for taking the time to join us. The Mental Health Association in New York State has a 50-year-plus history of educating communities about mental health and advocating for systems change and policies that promote prevention, intervention, and care for individuals and families impacted by mental health. One of our successful initiatives was leading a grassroots advocacy effort to pass a law in New York State, being one of the first in the nation to requiring mental health instruction as part of the K-12 health curriculum. In addition, we have successfully advocated for and been awarded state funding for the School Mental Health Resource and Training Center to support implementation of the law. We're really excited to share with you some of what we've learned. Our efforts really began with research in mental health literacy. We knew that there was a lot of great research coming out that was supporting programs like mental health first aid, and that was really sort of the impetus for our efforts. We know from mental health literacy that when individuals are educated about strategies to improve and maintain their mental health, when they have an understanding of mental health disorders and treatments that are available to them, and when they understand how to seek help for some of their challenges that they might be experiencing, what we get is a reduction in stigma, as well as people demonstrating positive attitudes about mental health and the ability to support one another. And it just made sense, if we can do this with adults in the community through programs like mental health first aid, why can't we do this in schools? And it was really an exciting opportunity for us, not only to bring what we learned to the school communities, but also to engage schools in that grassroots effort. We had support from stakeholders from all across our state, school counselors, school social workers, eventually the teachers unions, parent groups, youth advocacy groups. People were really interested in this, as well as our affiliate members across the state. And so through this grassroots effort, it took some time, as it always does, but we were able to get the law passed. In New York State, there is a required health curriculum, kindergarten through 12th grade. So that seemed like the most logical place to introduce mental health. Within the health curriculum, they were already talking about substance use and misuse and prevention. And so it was, a great fit for our schools. Also, it helped us really advocate for and draw that connection between physical health and mental health. We've used data along the way to help support our efforts. Most recently have been really excited about the Mental Health America's State of Mental Health in America 2021 report. There's been a lot of questions, of course, as you can imagine, about how the past year, both the pandemic and other events, have impacted mental health. So we're continuously updating our schools and our partners on some of the research and really kind of laying that foundation for why mental health is really important and needs to be talked to, as part of the school curriculum. We also took a public health approach to mental health education. So we didn't want to just talk to students about mental health. We really look at this as a public health problem, and so it needs a public health solution. So that means that we talk to schools about the best way to implement mental health is to bring instruction and education to families and adult caregivers, teachers as well. So we have this approach that mental health is a tier 1 approach. Everybody gets this universal understanding of what mental health is. Everybody from our bus drivers to our teachers in the classroom to student support services staff who have an understanding of mental health, but sometimes they need a little bit more education and information about that the idea that we all have mental health and get them to think beyond mental health disorders and think about mental health as something that we all have. It's an important part of our overall health. And we want to make sure that students have that understanding as well. We talk about mental health as a continuum. So this is much more than just understanding the signs and symptoms of a mental health disorder. Mental health is a continuum. And what are the things that we as students, as adults, can do to keep ourselves on the well end of the continuum? So a lot of our mental health instruction includes content such as coping strategies, building resilience, and that has become actually really, really important over the past year. So we may be biased, but I like to say that I think we've positioned our state and our schools pretty well as we entered this very unusual 2020. At the beginning of the year, our schools were talking very much about mental health and coping strategies, and that was on the forefront of all of their work. So it was timely, I think, mental health education in New York State, and we'd be happy to talk more about it if anyone is interested. You can contact us at mahanys.org. That's MHANYS.org. Thank you.
Hi, everyone. My name is Kelly Davis, and I'm the Associate Vice President of Peer and Youth Advocacy in MHA's National Office. And I'm incredibly excited to be with you all today to talk about the power and growth of peer support specialists. Peers, for those who don't know, are people with lived experience of mental health challenges and/or substance use disorders who receive specialized training to support others in their recovery journeys. And they've demonstrated over the years that they're an integral part of recovery and drivers of change, and not only in how we address mental health for individuals, but how we address mental health in policy, in programs, and within organizations. Peers help connect and inspire people specifically through their lived experience. They're able to connect with folks on a different level than folks without lived experience, and can also help them better engage in existing resources, increase their self-efficacy, and enhance their well-being. Peers and investment in the peer support workforce is especially important in increasing the availability of support in a field where we're often telling people to reach out for help, and many times they are met with a lack or absence of resources that can help them. We see that peers address conditions like depression, anxiety. They can reduce hospitalization, emergency department usage, and improve management of chronic health conditions that are often common for folks who are diagnosed with psychiatric conditions. But they also increase people's quality of life, really focusing on the things that make life worth living for all of us, including participation in things that are meaningful to them, whether that's going to work, going to school, or otherwise participating in their communities. We've seen rapid growth in the certified peer specialist workforce, with now, thanks to California, all but one state having or in the process of having a peer certification. And since 2001, where the first peer certification happened in Georgia, there's been a rapid growth of the field of certified peers, with tens of thousands of peers certified throughout the country. Peers meet and engage people where they are. And as we continue to see the growth of peer specialists, we're also seeing a growth in the areas and the settings and where peers are showing up, whether that's primary care, criminal justice settings, community mental health, schools, or more. States in particular have really supported the growth of peer support specialists. They pay for peer support through state and local money, but many states also rely on Medicaid to pay for peers. In addition to the things that they've done so far, there's many other ways that states can further the importance and impact of peers through policy to ensure that the workforce continues to grow and improve resources in the future. One of these ways is addressing reimbursement rates, as they need to change to provide peer specialists real living wages so that they continue to do their incredible work, but also be paid for the value of the work that they're doing. In many states, low reimbursement rates disincentivize the use of peers by employers and systems, and it also forces skilled peer specialists to leave the field because they cannot live on the wages that they're provided. Additionally, many leave the field due to lack of career paths that are available for other healthcare professionals like nurses or social workers who have tiered levels of licensure or certification. To grow their roles, keep people engaged in the workforce, and help transform services, states are moving or interested in tiered certification that allows peers to grow in their roles, responsibilities, and wages as peer specialists become the norm for service recipients and consumers and not the exception. MHA has been working on this through our National Advanced Certification to support the growth of peer specialists as states are increasingly using or interested in these tiered reimbursement and certification levels for peers. This is especially important for standardization as the requirements for peer specialist certification vary greatly across the country, where some have 40 hours of training, some have 108 hours of training, anywhere from 0 to 2,000 hours of experience to get certified. So increasing standardization, increasing wages, and increasing career opportunities and reimbursement for peers is an incredibly important thing for states to do. States also need to define peers through state or regulatory action to continue to legitimize their place in healthcare, both physical and mental health. While commissioners and many in the field of peer support know how valuable it is, this regulatory or legislative action will help the growing legitimacy of peers through payers and others in the field. And the definition should include and reflect all of the ways in which the peer support field is growing and how it's being used in different settings, like I mentioned earlier, whether that's primary care, respite care, forensic settings, warm lines, and all the other places where peers are growing. As we see an increase in distress among Americans, it's critical that people have the comprehensive supports that help them thrive and to bring people most familiar with the process and the struggles of mental health challenges and conditions into positions not just of service, but also of leadership. We look forward at MHA through our partners and our affiliates to working with you all on these critical issues. And thank you for helping us to build a world where everyone has access to the power of peer support. Together, we can ensure that systems not only address challenges, but also increase the well-being and quality of life of so many who are looking for help and desperately need it. Thank you.